Hi there, and welcome. My name is Jeff Bell, and on behalf of McLean Hospital, I'd like to thank you for joining us today for an up-close look at anxiety disorders in adults. These disorders are common, they're identifiable, they're treatable, but far too often people struggling with them fail to get the care they need because of misconceptions and improper treatment. So, what should everyone know about anxiety disorders? What signs and symptoms set them apart from other mental health conditions? And how can they best be treated with evidence-based approaches? We're going to get some experts, we're going to get some answers, I should say, from an expert today. Dr. Jacqueline Bullis is a staff psychologist with McLean's Division of Depression and Anxiety Disorders. She engages in a program of clinical research aimed at increasing the public health impact of evidence-based psychological treatments by applying a transdiagnostic approach to the diagnosis, treatment, and prevention of emotional disorders. Jackie, thanks so much for making time for us today.
Thanks so much for having me. I'm excited to chat.
Well, we're thrilled to have you with us. Let's start with a couple of key distinctions here. First, can you help us understand the difference between what we might call everyday anxiety and what might be called unhealthy anxiety?
Absolutely. Great question. So, one of the things that's really important to acknowledge is that anxiety is part of the human experience. And not only is it part of the human experience, it's a vital, critical part of the human experience. We need to be able to experience anxiety to survive and to thrive in our lives. And so, anxiety, as with all emotions, is really signaling to our bodies saying, hey, there's something going on that I should pay attention to, either internally or around me, and motivating us to respond to that in ways that can be really helpful and really productive. Oftentimes, when I have a patient come in for treatment for an anxiety disorder, we talk about this question. And the question is, if I could give you a pill right now and you'd never have to feel anxious again, would you take that pill? And very, very often patients say, yes, please, does that pill exist? I would really like to have that pill, please. And what we discuss is the idea that even if that pill existed, which it does not, I wouldn't give it to you because I would be doing you a disservice if you were never able to feel anxiety. Even thinking about this webinar that you and I are doing today, if neither of us had an ounce of anxiety and just showed up and we were just going to freestyle it, it probably wouldn't turn out as well as if we had put some thought into the points we really wanted to address and the information we wanted to communicate. So, anxiety is a really vital emotion, even though it can be uncomfortable to experience, right, in those normal day to day situations. But anxiety, like all emotions, does exist on a continuum. And I think that's what your question's really getting at, right? Like, where is that threshold where that normal experience of anxiety that can be really helpful and motivating behavior, when does it become less helpful? When does it become a problem, right?
Absolutely. So there
Yeah.
is that key distinction. I'm also wondering if there's a distinction between unhealthy anxiety and an anxiety disorder per se.
Yeah, so when we're thinking about this continuum of anxiety, right, you can almost think of that Goldilocks analogy. If somebody has too little anxiety, that can cause some problems for them. And we might see that in somebody who has developed a habit of really suppressing and trying to avoid their emotional experiences in ways that can also cause problems for them. And then when anxiety is in that sweet spot, it's going to signal to us, hey, there's something going on I should pay attention to. How should I respond to this in a helpful or effective way? But then when it's in that too much part of the continuum, and that's when we start to talk about clinical anxiety or potentially a diagnosis of an anxiety disorder. And the way that we understand that is really in these two domains of how distressing are the symptoms that somebody experiences, right? So what's the amount of emotional distress that occurs when somebody's experiencing these symptoms of anxiety? Is it more that somebody else might be in a similar situation? And then the second domain is how does this interfere in their lives? So somebody can have an experience of anxiety and dislike that experience of anxiety, but it doesn't really cause problems for them. They're able to show up and perform in work situations the way they want to. They're able to show up socially in the ways that are important to them. They can enjoy their downtime, their relationships. And then for some people, the anxiety rises to a level where they're not able to do the things that are important to them. They spend a lot of time thinking about and planning, how do I manage this anxiety? How can I sort of construct my life in a way where I don't have to be in these situations that are going to be anxiety provoking? As a consequence of that, their lives can feel really small and really constricted because it's really being dictated about how do I try to avoid something that might bring on an intense experience of anxiety.
How does self-awareness factor into all this? Do you find that people who are anxious and perhaps in need of some clinical care are aware that they need that care?
That's actually a really great question. And I think we'll talk about a few different statistics today, but probably one of my least favorite statistics, because it's so painful, is that despite there being really wonderful evidence-based treatments for anxiety that I know we'll get to chat about today, most people with anxiety disorders will never seek any treatment. So the research shows us that about a third of people with that clinical level of anxiety will ever receive treatment. And then the other thing that is just really awful when you think about how treatable anxiety is that even in that small, group of people who will pursue treatment for their anxiety, um, on average, they wait over 10 years from when the symptoms first become really, really hard to cope with and really interfering to when they try to seek treatment. It's over a decade. And this is something
Wow.
that we see in the research, but it's also really consistent with my own clinical experience. I can't tell you how often I'm doing an initial intake with somebody and we talk about, when did these symptoms really first emerge for you and when did they start to become a problem? And it's a decade, it's 2 decades that people have been living with and trying to cope with and suffering with these symptoms of a condition that is really treatable. And so that's something that I hope if people take away maybe nothing else from our talk today, I hope people really hear that anxiety is highly treatable. And if you have any questions of, is what I am experiencing that kind of normal everyday anxiety, or maybe is it something more? Go get an assessment and have somebody give you some feedback because there are wonderful treatment options available.
We will definitely talk both about treatment and about how to find that treatment as well as we continue with our
Yes.
chat today.
Yes.
Let's talk a little bit about anxiety disorders as the
Sure.
landscape for our discussion. Can you kind of walk
Yeah.
us through some of the more common varieties in adults?
Yes. Well, one thing I think it's helpful just to think about too is that anxiety disorders are so common. They're actually the most commonly occurring psychological disorder uh, in our sort of in our world. And I know in primary care, people are probably very often screened for depression. We talk a lot about depression in mental health, but anxiety disorders actually impact people on a much larger scale than depression in terms of the numbers. So but in a given year, maybe 1 out of 10 people will meet that clinical level for a major depressive disorder, but 1 out of 5 will for an anxiety disorder. So if we look at that in the United States, that's about 40 million adults a year are suffering from that clinical level of anxiety. So I just like to set the stage that anxiety disorders are so common. The most common anxiety disorder by the numbers is social anxiety disorder. So that's about 9 to 10% of people in a given year, of adults I should say, would meet criteria for social anxiety disorder. And social anxiety disorder is an interesting one because sometimes people think this is just my personality. I'm a small group person. I'm a one-on-one person. I just don't enjoy being in these large settings. And sometimes that can contribute to the decision to not get assessed or to not pursue treatment. But when we're thinking about social anxiety, we really want to think about this fear and intense anxiety in a social or performance situation that happens really consistently in those types of situations where the person is really concerned about doing something that would be embarrassing or humiliating in front of other people, or that they might display visible signs of anxiety that other people could tell that they're anxious, whether that be sweating or blushing, things like that. And generally, people with social anxiety disorder, they have a sense that, I'm more anxious in this situation than my peers or somebody else would be. So they have a sense that the anxiety might be a little bit excessive or out of proportion. And this is a big thing we'll talk about today with anxiety avoidance. They engage in a lot of avoidance. So they don't put themselves in situations where they might have to raise their hand in a class or present in a meeting or make small talk with somebody at a holiday work party or whatever it might be. And social anxiety disorder is one of the anxiety disorders that tends to emerge a little bit earlier than some of the other ones, and it's equally common in men and women. So some of the anxiety disorders we'll talk about, we'll see women actually suffer at a higher rate than men, but social anxiety disorder is one that affects them equally. So if somebody is listening to this and wondering, do I have social anxiety disorder? So thinking about sort of that like intense fear and anxiety in social situations that's really consistent. And if you've been feeling that way for about 6 months, it's a good sign to get evaluated and to see if you could benefit from treatment.
Okay, so that's social
Yep.
anxiety. What about generalized anxiety disorder?
Yeah, so generalized anxiety disorder you can think of as the worry disorder. It's really characterized by this excessive worry. And just like there's some normative amount of anxiety, there's absolutely a normative amount of worry. And where we sort of cross that threshold with worry and with generalized anxiety disorder specifically is when that worry becomes excessive. And so people are worrying more days than not about a lot of different things. So it could be about their work performance, about their social relationships, being on time for appointments, just really worry that's covering a lot of different areas versus just focused on one specific situation. And that worry is difficult to control. So you and I might have a worry thought pop into our mind and be able to catch it and say, oh, but I really need to redirect and I need to finish this email or whatever is in front of us. But somebody with generalized anxiety disorder is going to be really stuck by that worry cycle. It's going to be really hard for them to disengage from it. And they're also going to have some physical symptoms. And so when we're looking at assessing for that threshold for generalized anxiety disorder, I'm asking people questions like, do you often feel, particularly when you're worried, really keyed up or on edge or restless, like it's hard to sit still? You feel irritable? Do you experience muscle tension? Is it hard to concentrate or is it hard for you to make decisions? Do you have a hard time sleeping? It's really common for folks with generalized anxiety disorder to report they get in bed at the night, they feel so tired, and their mind is racing with all of these worry thoughts about what if this, what if that, all of these future things that may or may not happen. And so generalized anxiety disorder oftentimes co-occurs with depression. It's actually quite common for those both to occur at the same time. And it impacts women at almost twice the rate than it does men.
Okay, so we've talked about social anxiety disorder. We've talked about generalized anxiety disorder. What else falls under this umbrella?
Yeah, so panic disorder is also a common one. And panic disorder can almost be thought of fear disorder because so much of panic disorder is about this experience of intense physical symptoms. And so, if we think about what a panic attack is and how that maybe that's different from an anxiety attack. So, a panic attack is a really intense, sudden onset of physical symptoms that can range from heart palpitations, feeling dizzy, lightheaded, even feelings of dissociation sometimes people will experience. And these are so intense that oftentimes when people have their first panic attack, they go to the emergency room because they're worried they're having a heart attack. And just because you have a panic attack doesn't mean you're going to develop panic disorder. And we'll talk about that in a minute. But sometimes people will talk about intense experience of anxiety and wonder if it's a panic attack because anxiety can be a very physical experience, right? We can all have that knot in our stomach or racing heart or feel lightheaded or even dizzy. The distinguishing factor is for a panic attack, it's going to come on really suddenly. Those physical symptoms are going to peak in less than 10 minutes, and then your
Mhm.
body's going to come down from that really intense state of activation. Whereas if we're having something that's more of like an extended period of anxiety, we can still have some strong physical symptoms, but they can be elevated for a much longer period of time. So if you sort of had a graph here, you could sort of be fluctuating in this moderate range where physical symptoms in a panic disorder are going to have that really quick onset peak and they'll start to dissipate. And then when it turns into panic disorder is when after somebody's had a panic attack, they have really pervasive worry about when is my next panic attack going to happen? When am I going to have another panic attack? And what are the implications of that, right? So what would happen if I had a panic attack in this situation in front of these people? Or what would the impact be to my health? People might have concerns about their heart health and things like that related to a panic attack, and then they start avoiding things. And so they might avoid certain situations where they feel like they'd be more likely to have a panic attack. They also might avoid particular activities that bring on physical sensations that are similar to what they experience in a panic attack. So it wouldn't be uncommon for somebody with panic disorder to avoid caffeine, to avoid intense exercise, a sauna, scary movies, sex, anything that brings on like a lot of that autonomic arousal that can feel similar to a panic attack. People may try to avoid. Um, and then sometimes people also develop agoraphobia in addition to panic disorder. And the agoraphobia really references that fear of how would I escape if I was in a situation and I had this intense onset of physical symptoms, or if it were to happen in this situation, it would be particularly embarrassing. So people start to avoid all different types of physical situations, ranging from, taking a T, flying, being on the highway or in a tunnel, waiting in line, even getting haircuts. Because the idea of what if I had to leave, when I've got the little cape on and my hair is halfway cut and I'm having these symptoms and I have to leave, it would be so embarrassing. And then I would have uneven hair, right? So it can really manifest in so many different situations.
So you touched on this briefly in your last response there. Are phobias part of anxiety disorders as well?
Yes, so phobias are the most common of anxiety disorders. They can impact like 10 to 13% of adults in a given year. And so specific phobias are interesting because oftentimes they are things that arise in childhood. And so when we look at the most common types of phobias, they tend to be around specific animals, whether those are spiders or insects, snakes, things like that, and then heights. So women suffer from phobias at twice the rate of men. It's another anxiety disorder where we do see that difference in gender. And this is different than I don't really like a snake or I don't really love flying. We're talking about a really intense fear of a specific situation or a specific thing that is consistent, it's pervasive, and people avoid it. Or if they can avoid it, they're enduring it with a lot of distress. So just because you fly, for example, doesn't mean that you don't have a specific phobia or flying. If you're somebody who is unable to sleep the nights leading up to flying, you have maybe special things you need to have with you to feel comfortable. You are taking medication or making sure you're hitting that airport bar before the flight. You're gripping on. You're checking the turbulence. That would be a specific phobia of flying. And so sometimes I think people get confused if they can survive a situation, does that mean it's not a specific phobia and I don't need treatment? And that's not true.
Okay, anything else under this umbrella that we're calling anxiety disorders before we move forward?
I think those are the most common ones that we see. One of the things that's interesting, there's been some research that actually shows that so specific phobias tend to have an earlier age of onset than other anxiety disorders, and they're really predictive of people developing other anxiety disorders and other emotional disorders on top of it. So something that if somebody is listening to this and thinking, I might have a specific phobia, if you treat that now, that could actually be preventative in developing other anxiety disorders down the road. So uh, just something to share with the audience.
And Jackie, let me ask you this. I don't want to get us
Yeah.
off into the weeds, but if I'm not mistaken, OCD used to be considered part of the
Yes.
anxiety disorder spectrum. It is no longer, if I've got that right. Can you explain why and what we should know about OCD relative to anxiety disorders?
Yes. This is a big area of debate in the field and actually has been for decades whether OCD should be in this grouping of other anxiety disorders or if it should be taken out and separated. And in our most recent edition of what we call the DSM, and that stands for the Diagnostic and Statistical Manual of Mental Health Disorders, and that's sort of our diagnostic Bible as mental health providers. And it gets revised every now and again based on new research and how we understand the brain and these different disorders. And the most recent edition is the fifth edition. It came out in 2013. And in that change, they did decide to remove OCD from the grouping of anxiety disorders and put it in its own category of OCD and obsessive compulsive spectrum disorders. But they very intentionally kept it next to anxiety disorders in terms of the order of chapters because they want to signal that it's still closely related to anxiety, but there are enough features that make it different. And so when we think about why that was, there are a few reasons. Some of it has to do with different biomarkers in the brain and different genetic risk profiles. But I think, the maybe the most convincing, especially when we think about this from a clinician's perspective, is that although anxiety is certainly part of the experience of OCD, and folks who are suffering from OCD will talk about that experience of anxiety, the loop that categorizes an OCD experience is a little bit different, where you have this intrusive thought or this compulsive thought, and then there's this distress related to it, and there's an urge to engage in a compulsive behavior or ritual to try to neutralize some of that distress, and then you have that temporary relief. And so if you look at that particular cycle, it differs a little bit from other anxiety disorders, even just in the nature of the experience of the intrusive thought. And so based on that, there was kind of a consensus in the community that removing OCD and related OC spectrum disorders from this greater grouping might help develop a deeper understanding of the specific mechanisms at play, and potentially help develop more targeted treatments for people suffering with OCD.
That's all very fascinating. Let's keep our focus on anxiety disorders per se.
Sure.
I do want to let our audience know that we're going to come back and talk a lot about treatment and what you can do about these conditions. Because as you
Yes.
mentioned, and this is so critical, these anxiety disorders are highly treatable with the right treatment protocol. But let's talk about diagnostics first. This is an area that
Yep.
you spend a lot of your own time and research in. What is the typical process for diagnosing an anxiety disorder, if there is such a thing?
Sure. So we could almost talk about this as what most often happens versus what would be an ideal process, because the ideal process happens so rarely in real life. And so what most often happens is when somebody starts to experience more intense symptoms of anxiety and they're considering seeking help for it, the first point of contact for most people is going to be their primary care provider. And one issue with this is that oftentimes primary care providers are not as well educated in the current best practices for the treatment of anxiety disorders. And so, and there's a few things that I think contribute to this, but most often somebody in that situation will be prescribed a medication. And while there are medications that can be helpful for anxiety disorders, most of the research shows that other types of psychotherapy, in particular cognitive behavioral therapy, is more effective than medication for anxiety disorders. And when you ask patients, would you rather take a medication or would you rather do a form of talk therapy to teach you skills? People 3 to 1 would prefer to learn skills than um, to take a medication of some sort. And I think this really gets at something that I'm particularly passionate about, which is sort of consumer education when it comes to mental health disorders, because I have had a number of patients that have suffered through the experience of anxiety and side effects of medication, and delayed starting families because they didn't feel they were able to go off of their anxiety medication, and nobody told them about cognitive behavioral therapy. And by the time they get to a specialized treatment center that provides really high quality CBT, they've suffered a lot. And oftentimes with anxiety disorders, in as little as 12 to 16 weeks, we can make an incredible difference in how somebody's feeling, incredible reduction in their symptoms, improvements in quality of life. A lot of people we would consider to be in remission after such a short course of treatment. And so unfortunately, people oftentimes have a lot of sort of wrong turns before they arrive at a place where they can get what is considered and recommended by national clinical guidelines. It's recommended that the first line of treatment, and this is globally for anxiety disorders, should be cognitive behavioral therapy. And the majority of people who try to seek treatment for their anxiety disorder will not receive CBT. And so that's a really, really sobering and sad state of access to high quality mental health care that we have here in the United States. Uh, and so one of the things I'm really passionate about is at least trying to empower patients and to empower individuals to know what to look for and to know what to ask for, even if it can be hard to find it out in the community. So that's what happens most often, is that there's no real specific detailed intake. Somebody will report feeling anxious and they'll be offered a prescription. But in an ideal world, what would happen is somebody would go and do a more thorough diagnostic interview. And so this is going to listen to whatever motivated somebody to come into treatment, but it's also going to ask questions to make sure we get the full picture. Because somebody will come in, this is an experience I had at an anxiety clinic where I worked, where a woman came in for treatment, and on the phone screen it said it was for social anxiety. And when you first started talking to her, she talked about how she was embarrassed to have people over. Her social world was really limited, really constricted, and it sounded at first blush, yeah, this sounds like social anxiety. And we went through the full interview where I asked questions about all the different anxiety disorders and different mood disorders, and it turned out that this woman actually had a hoarding disorder. And so the reason that she was so embarrassed to have people over was related to the hoarding. It wasn't social anxiety. And so if we had just jumped into treatment for social anxiety without doing a more thorough intake and assessment, we would have missed this piece that was a huge piece of her diagnostic puzzle, and it would have prevented us from giving her the best possible treatment.
And so what you're saying there is the questioning, the communication during that intake is so key. And is that what's getting missed sometimes in terms of diagnosis?
Well, I think, our primary care providers are so pressed for time. And so they have such little time to address behavioral health or mental health concerns. They certainly don't have time to go through a full diagnostic interview. And then patients often don't have a more specific sense of diagnostically what they're experiencing. And why would they? They haven't necessarily gone to school or been trained. And so what you most often see as a label in somebody's chart is something called anxiety disorder not otherwise specified. And that means we know this person has anxiety of some nature. We're not sure if it's more of the generalized anxiety or more social anxiety, or maybe there's some panic disorder presenting. We know it's a flavor of some of that, but we either don't have time or we don't have the tools to narrow it down more specifically. Because when you look at the number of people who are in our healthcare ecosystem providing mental health care treatment and the number of people who need it, it's a huge burden of need for mental health treatment, and so few people who are trained to provide it. So there's a really big gap there that makes it hard for any mental health care provider to sometimes do as thorough of a diagnostic intake as they want. And so you also see a ton of misdiagnosis too.
We mentioned earlier that you do a lot of work in the transdiagnostic arena. What does that term mean, and how is it relevant to this
Yeah.
conversation today?
Yeah, so transdiagnostic is really a fancy way of saying that when we think about how we group different disorders together, we can group them in different ways. So one of the ways is by symptoms. And so this is how our current diagnostic system, the DSM that I referenced, works. So it basically says if you have this collection of symptoms over this period of time and it bothers you, it causes interference, you have this disorder. And that's been how we communicate. That's been how we've focused our treatments for many years in the field of psychology. And the problem with that is there's a few problems. Number one, sometimes it creates this artificial threshold of, if you have four of these five symptoms, you don't have depression. But if you have five, you do. And that doesn't mean that that person with the 4 out of 5 wouldn't benefit from treatment and isn't suffering. And so sometimes those thresholds can feel a little artificial. And then the other thing is that comorbidity, and by comorbidity, I just mean having more than one diagnosis or more than one disorder, is the rule in mental health disorders. It's not the exception. So if somebody comes in for an assessment and we go through one of those thorough assessments I was describing, the average person is going to receive 2.3 diagnoses. And the reason for that is because there's so much symptom overlap, right? So even when we were just talking briefly among the anxiety disorders, we talked about worry as being a cardinal symptom of generalized anxiety disorder. We talked about in panic disorder, worrying about having another panic attack. We talked about in social anxiety, worrying about how we might be perceived, and do we do something that embarrasses ourselves in front of other people. So worry is one of these processes that actually cuts across disorders. It cuts across these diagnostic processes. And so a lot of the work that I did during my doctoral studies and the work that I still do today is saying, you know what? Instead of focusing on all of these, unique things between disorders. So, how is social anxiety different from generalized anxiety? What if we actually focused on these processes that are common across anxiety disorders? And in doing that, could we develop a treatment that was more efficient and would be easier for providers to get trained in? And so the idea is that instead of coming in for treatment and maybe you need treatment for your social anxiety, major depressive disorder, some sleep difficulty, and maybe you also have a specific phobia, and you'd have to go through a course of treatment for each of those. The transdiagnostic approach says these things actually have more in common than they do that differ across them. And so, what if we could just do this one kind of holistic treatment approach that focused on these core processes and these vulnerability factors? And could we do this more efficiently? And so that's really what it means to do something from a transdiagnostic framework, focusing on these processes that are shared across disorders. And the field has really been moving in this direction because it's more consistent with what we actually observe out in the real world when assessing and treating people. And it's more affirming for patients because patients are able to talk about all of the things that they're experiencing instead of saying, well, we're really focused on my social anxiety. So I guess I can't really talk about the fact that this other stuff is going on that's also hard for me. So that's feedback that we get from patients that they really like being able to talk about all of the different things they're experiencing and how it impacts them.
That's fascinating. It certainly makes a lot of sense as well in terms of the evolution of the field. Let's talk treatment. This is such a key part of our
Yes.
discussion today. You've touched on this a little bit in a couple of your prior responses. Cognitive behavior therapy. What are we talking about with
Yes.
CBT, and how is it applied in the treatment of anxiety disorders?
Sure. So CBT, as I mentioned, should be the first line treatment that anybody with an anxiety disorder receives before they try something else. So it doesn't mean that it works for 100% of people. It works for the majority of people, but it's really hard to access in the community. Maybe we'll talk about that a little bit. But CBT is really focused on, it's a short term. It's a skills based treatment and it's focused on helping people learn how to identify different thinking and behavioral patterns that get them stuck in these places where they're not able to live the life that they want to live. And so it will help people learn skills to notice and challenge some of the negative thought patterns that can really keep us stuck. And also, how do we implement more effective or more helpful behaviors when we're having an intense emotion? Because what happens with an anxiety disorder, because of the way that we're wired as humans, is that when we're feeling something distressing, we want to get rid of that feeling as fast as possible. And so that oftentimes means avoiding the experience, leaving a situation, doing things to try to like really push down or turn down the volume of the anxiety. And that works in the short term, but in the long term, it keeps us stuck because it teaches us we can't cope. It can cause all kinds of functional problems if we're avoiding different things in our lives that are consistent with our values that we do want to be able to do. And so CBT really helps people develop that emotional awareness and implement these tools to be able to recalibrate the intensity of their emotions.
Okay, here's another term we often hear around
Yep.
anxiety disorder treatment: ACT, acceptance and commitment
Yes.
therapy. Is that distinct from CBT? How does it dovetail with CBT? What should we know?
Yeah, so ACT is oftentimes referred to in the field a third wave type of CBT. And so this encompasses a few different approaches that have developed out of CBT that mostly integrate more mindfulness approaches. So ACT is a treatment that utilizes a lot of that Eastern philosophy of mindfulness. It still is a behavioral therapy, and it really focuses on helping people identify what are their core values, what are the things that are most important to them, and how can they accept their intense emotions and move forward in life in a way that's consistent with those values, even if sometimes there's pain with that. And so it is a treatment that a lot of people really enjoy, particularly folks who appreciate that mindfulness element.
What else is part of the treatment mix?
For ACT, or
I'm
for
sorry, no,
treatment for
for anxiety
anxiety
disorders in
disorders.
general.
Oh, sure, sure. So I would say that ACT and CBT are sort of the two primary evidence-based approaches. And then sometimes medication is a piece of that, right? Sometimes medication helps people be able to come to treatment. Oftentimes, when people present to treatment and they're taking any kind of short-acting anxiolytic medication, that's something that we'll talk about as a goal of weaning that person off and teaching them that they can cope with their anxiety when it emerges. And then, even though it might be a little bit more effective for depression, there is a great body of research around exercise as a way to cope with moderate anxiety and other mood symptoms. And so, one of the nice things I like to tell people about when we're looking at exercise as a way to augment our mood, it actually just needs to be of a moderate intensity. You don't have to go to a really intense, high interval training or a really intense spin class. It can be like 20 minutes of a moderate form of exercise that you enjoy, and that actually optimizes the mood boost that you get. And if you overdo it and you're doing more intense exercise, it actually delays that mood augmentation impact. So exercise can be a great strategy to integrate into treatment that folks can try.
I want to ask you also about different levels of care. We hear about outpatient treatment, inpatient or residential programs, partial treatment programs. What are those terms getting at?
Sure. So outpatient therapy is typically when you see a provider, normally once a week, and you're either meeting virtually or you're going into their office for typically a 45-minute to an hour session. Um, for some people, that level of care is not sufficient. They need a more intensive level of support, and that's where a partial hospital or an intensive outpatient treatment setting might be right. And those are where somebody is going for the day from maybe, 8 to 3, for example, and they're going to a program for a short period of time where they are going to get support potentially around medication adjustment. They will attend different groups to learn some skills, and they'll also have an individual provider meeting with them and helping them implement skills. And so that can be a good sort of intermediate level of care before somebody rises to the level of needing inpatient care. So for folks who are coming from outpatient into a partial, our goal is to prevent them needing to be hospitalized.
And what does residential look like for somebody with an anxiety disorder typically?
Yeah, so it can look like a few different things. So for an inpatient stay, folks typically are experiencing symptoms that are so intense and so severe that they're not functioning. And oftentimes there's a safety concern, whether that's about risk to themselves, occasionally risk to others, but most often with anybody struggling with a mental health disorder, we're worried more about them being a source of harm to themselves. And so if there's any kind of safety concern, that can be a big driving factor for an inpatient hospitalization. Sometimes it's helping to adjust meds in a really supported setting where there can be a lot of observation. But generally, inpatient stays are very brief. And then we want to get somebody stepping down to that partial level of care as soon as possible so they can really engage in more skills-based work to manage their symptoms and then getting them transitioning back to outpatient as soon as possible.
Let's talk a little bit about what somebody who is a loved one of somebody with an anxiety disorder can do to best support them. Whether that's helping them find treatment or helping them through the treatment process. Let's focus on adults, supporting other adults. What does that look like, and what guidance do you have for those loved ones?
So one of the things that's really tricky when you're a loved one of someone who's struggling with anxiety is that in efforts to want to help them or lessen their pain, we can oftentimes end up accommodating their anxiety in ways that are not helpful. So we might see this where somebody has panic disorder, for example, and the idea of being in a crowd or being in certain situations is really anxiety provoking. And so they will always bring a family member or a loved one, right? And so the loved one might feel like, well, I'm helping this person. Um, and the effort is of course really sincere and lovely, but the impact is that that person, that patient, or that individual with the anxiety is learning that I can't cope with this unless I have a safety person with me, and there is something really dangerous to the point where this person is agreeing I need this extra support. And so we see this a lot. I know we're talking about OCD as no longer an anxiety disorder, but there's a lot of similarities in how we treat OCD with other anxiety disorders. And you see this often where, let's say, somebody with OCD has intrusive thoughts or compulsions around checking or touching or tapping something a certain number of times until it feels just right. And so they might say to a family member or a partner, can you be the one to check the stove before we leave? Can you be the one to turn off the light? Because if I do it, it's going to trigger this urge to engage in these different compulsive behaviors. And family members might feel like that's being helpful when really in the long term, it's keeping that person stuck. So it's something that it involves doing something that can feel hard in the moment for the long-term benefit. And so that's something for family members to be maybe aware of or curious. Like, I know this, my loved one really wants me to do this, but am I confirming the idea that they can't cope with this? Am I making it easier for them instead of helping them develop skills? And then the second thing I think is, if the loved one is open to it, is having conversations about, how would you like to be supported? Could I be helpful in helping look at different treatment options? Unfortunately, the landscape of mental health care is such that it's really hard to find a therapist. It's even harder to find a therapist that's well trained in CBT or one of these evidence-based approaches. There are issues with insurance coverage. There's often really long wait times. And so if you think of someone who's really suffering with anxiety and perhaps also struggling with some depression or low mood, if that loved one is comfortable being the one who makes those initial phone calls or helps with some of the logistics, can be a wonderful way to support them. Um, so it really depends on sort of how much help someone's willing to accept. But sometimes people will really bring a partner or a loved one into treatment to help them be accountable for practice in ways that are really wonderful. And sometimes people like to keep it really separate. So there's a lot of variability there.
We have a lot of clinicians typically in our audience for this video series, and I want you to speak to them directly in terms of what you would like to see them know about anxiety disorders in general, and at what point you think it might be appropriate for them to refer out if the challenge becomes difficult in terms of a diagnosis or a treatment for an anxiety disorder.
That's a great question. I think one of the biggest things that I see in clinicians that I train out in the community is that because exposure is such a key part of CBT, that's the behavioral piece, it's the B in the CBT. And exposure involves deliberately confronting a feared situation, learning that you can experience that anxiety. The anxiety will come down on its own without you trying to manage it, and that you are able to tolerate it, right? So building that sense of self-efficacy, learning that those situations aren't as scary as maybe you predict that they will be, um, without having proper training or support. Those types of exposure therapy exercises can be really intimidating for clinicians to do, because they can involve, I have gotten in cars with people, and gone in tunnels. I have done all kinds of really intense exposures. And sometimes we're doing exposures to physical symptoms themselves, where we're encouraging the patient to hyperventilate, to, run up and down stairs, doing things to bring on these strong signs of autonomic arousal. And that can be kind of scary to do. It was scary for me as a clinician when I was first learning. And so I think one thing I would want clinicians to know is that that part of treatment for anxiety disorders is so important. It's one of the core mechanisms of change. And if you haven't been trained in it, or you've gotten some training and you don't quite feel comfortable, there are so many wonderful resources out there, from on demand, training materials you can view, amazing workbooks that we can talk about later that you can use and you can work through with your patient. But just to normalize that it can be nerve-wracking to use some of these strategies with patients, and they're so important. And so really just encouraging people to find resources to get training in these types of CBT and exposure-based treatments.
And just to put the finest point possible on this discussion with exposure, is what you're describing what we sometimes hear described as exposure response prevention, ERP? Is that part of the anxiety disorder treatment protocol?
Yeah, so exposure and response prevention, ERP, is really considered the gold standard of treatment for OCD. And this was also a contributing factor to why OCD was removed from that anxiety disorder grouping and put next to it, but in its own category. And ERP is a really behavioral treatment. So it doesn't have the C of the cognitive in CBT. And exposure and response prevention therapy is kind of just like what it sounds, where really immediately, the second session, if you're doing an ERP treatment with somebody, you are exposing them to whatever object or situation is going to trigger that distress and that urge to engage in compulsive behavior. And you're helping the person like ride that urge out and not engage in it. So they learn that they can tolerate it, and the urge is going to get a little bit weaker each time that they do it. And there's a lot of repetition, where CBT has a whole cognitive component where it's really focusing on catching thoughts, evaluating the thought, saying, is this accurate? Do I have any evidence that supports this? Am I falling into a thinking trap where I'm only considering one part of the evidence, or I'm catastrophizing, I'm thinking it's going to be much worse than it would be, or I'm jumping to the conclusion that, there's this one potential negative outcome. And instead of seeing that as one of many, I'm saying it's 100% going to be this worst outcome, right? And so you see that with CBT, and that's a big part of the treatment with anxiety disorders, where ERP is really behavioral and just that repetition of helping people learn to resist, and eventually the intensity of those urges decreases with time. A great
That
question.
makes sense. No, that makes sense. And I appreciate you making that distinction for us. I want to sort of wrap things up by talking about what somebody might expect post-treatment. As we've
Yeah.
discussed throughout this conversation today, these disorders are highly treatable. Can you talk a little bit about some of the success stories you've seen over the years?
Yeah, this is a great question, because one of the things that's maybe different in treatment with CBT than somebody who has experience seeing a more supportive therapist, where you go in for your session and they say, what's on our agenda? How did your week go? CBT is a much more structured approach, where there are specific skills that your therapist is going to be working to teach you. And there's a lot of practice that goes on in between sessions. So you're going to get homework. And homework is a really big part of CBT, because if you think about it, you see your therapist an hour a week. That's like less than 1% of your week. And if you have to wait until your next session with me to feel better, I'm not doing my job. I want you to have the skills to basically become your own therapist. I want to make it so you don't need me anymore. And so sometimes a coach analogy is a better description of what it's like working with a CBT therapist, where the patient comes in with their expertise and their own lived experience. And then I have my expertise and the types of strategies that are most effective for addressing their symptoms. And so, because CBT is skills based in this way that I'm describing, oftentimes we'll stop treatment before somebody has made all of the progress that they want. So they might have shown that they can really implement these skills and they've seen some significant improvements, but maybe they still would like to do a little bit more. And we'll say, you have the tools, you know how to practice these. And so we'll send somebody off to continue to practice. And what's really cool is when you look at the research studies that are done on CBT for anxiety disorders, most of the time treatment is standardized at about 16 weeks, so 16 hours of treatment. And at the end of that, we see this incredible decrease in the intensity of people's symptoms. We see their quality of life go up. That impairment we talked about has gone down. People feel really good, but they might not feel 100% recovered. And we say, but you've learned what you needed to learn. And so we send them off, but we still track them. We still assess how they're doing over this extended follow up. And we see in that 6 months, people continue to get better without their therapist, because they have the skills and they're practicing them more, they're integrating them into their daily life. So it just becomes part of their new normal. And so, one of the things that I always really impress on people when I'm finishing up treatment, particularly my patients who say, well, yeah, I'm doing really well in these ways, but I still sometimes struggle here. I say, that's okay. And you're going to have times where either you're not feeling well, you're sick, or there's a lot of stress at work, or you're going through a tough spot with your roommate or your partner, and your symptoms might increase a little bit. And that doesn't mean that you're having a relapse. And so, learning to expect that there is going to be some ebb and flow, and to not panic when that happens, because it's just part of how symptoms fluctuate, and that they have the skills that they need to cope with those periods. And then I let people know that if it feels like those symptoms are continuing over time to sort of ratchet up for them, they're starting to feel like the symptoms are getting in the way, you can come in for something that we call a booster session. So you're not committing to a whole new course of treatment, but you can say, hey, I feel like I just need a little tune up. And maybe somebody comes in for like 2 to 4 sessions, and it's just a refresher and helping people get back on track, really revigorating that skills use. And I really encourage people to do that sooner rather than later, because just like it takes people sometimes over a decade to pursue treatment, I've noticed that oftentimes people who do really well with CBT, they're doing great. They don't meet a threshold for a diagnosis anymore. They go out, and then maybe over the course of a few years, those symptoms start to increase a little bit, and they wait until things get really bad before they come
Yeah.
back in for treatment. And so I always like people to know that you can kind of come in for that tune up, if you will, those booster sessions, so we can get you back on track sooner rather than later.
Okay, before we let you go, resources. You've mentioned a couple along the
Yes.
way. Do you want to share some thoughts in terms of where we might point people for additional background on anxiety disorders and their treatment?
Yeah, so there's a few really great resources. So one of them that I'm closely involved with is the Anxiety and Depression Association of America, ADAA, and that is a wonderful resource for both public education. I'm actually on their public education committee where we're writing blog posts, we're publishing the most up-to-date information on how to think about and understand anxiety disorders and mood disorders, and there's opportunities to ask a therapist questions. There's lots of great resources for community members and people out in the community. And there's also really great professional community, or excuse me, professional education webinars and materials. And so I would really encourage people to check out ADAA. They also have a really great find a therapist search feature where if you're looking for somebody who is likely to practice these types of evidence-based treatments for anxiety disorders, you can search based on where you live to see if there's somebody that would fit your needs, potentially take your insurance. Another one is ABCT, which is the Association of Behavioral and Cognitive Therapy. They also have really great resources for both providers and professionals, and then the larger community. And they also have a find a therapist function that can be really helpful in trying to find people that do have this training in CBT. And then another great resource that you can use as a self-help guide, or sometimes people will bring this to a provider they're already working with who maybe doesn't have as much CBT training and say, can we do this together? There's a series of therapist guides and of client workbooks published by Oxford. It's called the Treatments That Work series. So to be accepted into this series, it means that you've had to demonstrate a robust amount of research that this treatment works. And there's a number of manuals that are focused on specific anxiety disorders. So, mastery of your worry and anxiety for somebody with generalized anxiety. And then there's also a transdiagnostic treatment called the Unified Protocol that really helps people learn skills to tolerate and respond to their emotions more effectively from a more holistic sense. And so those are great resources that you can either work through the workbook on your own, or you could potentially bring into a treatment relationship and say, hey, would you be open to doing some of this together? And those are great resources to really find evidence-based information and treatment resources, because that's the thing that I want people to really take away from this, is that there are a lot of people who have pursued treatment and been really disappointed in the impact, right? They might have invested a lot of time and money in treatment and felt like it didn't really move the needle in their symptoms or in their pain. And more often than not, when I talk to somebody like that and I ask them to tell me, what did you do in treatment? What did your treatment look like? Did your therapist do X or Y? They didn't receive CBT. And so it's an unfortunate reality that in mental health that isn't more regulated, and it is a little bit of a wild west of what exactly your provider is practicing. Sometimes they might say they're using CBT, but it's not really the CBT that we would consider the gold standard for treatment. And so it can make it tricky as a person seeking treatment to know am I getting what I should be getting? And so all of these resources can be really helpful in making you a more informed consumer and connecting with providers who are more likely to practice these types of evidence-based treatments.
Boy, Jackie, I've got to say, I really appreciate and admire your commitment to educating people out there. And you've done a lot of educating today, helping us better understand how to address anxiety disorders in adults. Thank you so much for your time.
Oh, it was a pleasure. Thank you so much for having me.
Dr. Jacqueline Bullis, and to those of you watching, thank you for your interest in our educational outreach. We hope you'll come back for our future presentations, and we wish you a wonderful day.